With trauma and burn surgical critical care, we see all types of wounds. The type of wounds that I see are everything from total skin sloughing to total third degree, second degree burns, a lot of trauma wounds, a lot of road rash that is converted to burns, things called like toxic epidermal necrolysis, things that the local doctors or the doctors in the state don't know what to do with because they've never seen it. We see it just about every day. Most of them come in filthy dirty, and that means bacteria. And if, of course, you get dead tissue, that means that that bacteria now is infecting that dead tissue, which means that the patient is just a meal for the bacteria. And then we have to come in and excise that or clean it up some way. Classically, a lot of those patients end up going to the operating room to get their wounds healed, if you will. When we look at that wound, we have to decide how soon is the operation, how deep is the operation, what is the scope of the operation, and how soon we can get them back to who they were, which is the objective for any patient. How can I get back to me? My main objective in treating a wound is to remove the dead tissue, okay? Get the dead tissue off and control any infection that's there. How are we now going to try to get that granulation tissue to develop so that we can get this wound closed? Well, there are various things. Standard wet to moist dressing. Standard wet to moist dressing is stuff that I used when I was an intern back in the dark ages. Okay, we've graduated from that. We know a lot more about wound care and how to treat patients and how to treat their wounds. Things like, for instance, negative pressure wound therapy. What does that do? And we've known this for 25 years to help granulate that wound bed up so that we're going to be able to get it skin grafted. But then something else came along called installation. And now we have 3 arms, 3 strong arms to try to get that wound granulated to get it to heal. So we can use all of these things, negative pressure wound therapy, which has the macrostrain and the microstrain, and installation to help us get that wound to granulate, to get it towards closure. Okay. I'm never using standard negative pressure by itself ever again. My question is, why wouldn't you use installation on everything? If it's on a skin graft, I'm going to use standard care. I get that, because you're not going to instill over top of a skin graft. Got it. But for every other wound, I'm trying to find a reason not to put installation in it. It's like going to the operating room every 2 to 3 hours, washing that wound out. That's the glory of this device, is that we can change negative pressure wound therapy out. We have installation now, and treat them with repeated washing out of that wound. This is where 3M knocked it out of the park. If we go back and we look at the Gabriel meta-analysis or the Kim economic paper, we will see decreased length of stay, decreased number of operations, decrease the time to closure, and for follow-up, more wounds closed. So in the end, the patient gets out faster, they're closed faster, there's huge cost savings. And as a result of this, the healthcare burden to society, the healthcare burden to insurance companies, and to the patients themselves. So this is a win all the way around. Everybody wins in this scenario. Welcome to 2022. Here we are.